would like to invite Dr. Bharti to discuss laser management in RVO patients.
Thank you, Dr. Aditya. Good morning, everybody. I will be talking about the role of retinal photocoagulation in retinal vein occlusion. So this is the overview. We'll be talking about the types, indications, benefits, limitations, and the current trends in the RVO management. So we know how photocoagulation works. It causes the scarring of the retina, leading to decrease anoxic areas and decrease VEGF. So there are different types of photocoagulation. It can be scatter or pan-retinal type, sectoral or grid laser in the periphery, or focal laser photocoagulation. It treats widespread retinal ischemia by creating multiple burns throughout the mid-periphery and peripheral retinas. Now, as has been discussed earlier, BVOS, CVOS, BRVO, and CRVO studies have already established the role of laser treatment in RVOs. And as my colleague Dr. Aditya has already discussed, the first line of treatment is now shifted to anti-VEGF therapy. So laser therapy now acts an adjuvant and it decreases the frequency and number of anti-VEGF injections. It also helps in prevention of retinal ischemia and neovascularization and eventually neovascular glaucoma in ischemic cases. Patients in whom prolonged injection course and frequent office visits for injections are not possible, laser can be considered. Patients with medical comorbidities where anti-VEGFs and steroids implants are contraindicated also seek benefit from laser therapy. Patients that have minimal response to anti-VEGF injections are also considered for the laser photocoagulation. Now, role of photocoagulation in ischemic CRVO. As we know that ischemic CRVO can lead to neovascular glaucoma, also known as 90-day glaucoma, as it commonly used to present around 3 months, which has now shifted to 180 days or 6 months after the initial ischemic event. So, the prevention of neovascularization is caused by peripheral retinal scarring, which would eventually decrease hypoxia and angiogenic factor production. Long-term visual outcomes, as we know that PRP would stabilize the visual function in many patients, although it may not restore vision in severe ischemic damages. Integrating it with anti-VEGF therapy can optimize patient outcomes. Now, is the neovascular glaucoma is a complication of all type of CRVO? No. So, while deciding for the photocoagulation, we must know what is the role of PRP in prevention of NVG. The risk of CRVO developing into neovascular glaucoma is only 7 to 8%. And PRP has deleterious visual side effects like loss of visual field. Now, role of focal or grid laser in BRVO. It prevents neovascularization in patients with significant retinal ischemia. It also manages macular edema. Targeted focal laser treatment can effectively address macular edema. Long-term visual outcomes in photocoagulation helps in sustained vision acuity improvement. Long-term studies have revealed that retinal photocoagulation significantly enhances visual acuity in patients with retinal vein occlusion, with approximately 70% maintaining or improving vision over extended periods. Like in the diagram also you can see with the laser, the macular edema also decreased over time. Now there are a few limitations and considerations with the PRP or the laser photocoagulation in RVOs. It does not address the underlying blockage. It does not remove the initial blockage, so requiring concurrent management of risk factor is required. It can cause disturbance in the potential visual acuity like visual field loss and in few cases vitreous hemorrhage as well. Patient selection criteria is by identifying appropriate candidate for photocoagulation that requires thorough assessment of individual risk factors, health status, and specific visual needs. So the current trends in RVO management is that with the effective use of anti-VEGF agents in conjunction with laser treatment, now we have a more comprehensive approach to managing RVOs. With the advancement in anti-VEGF therapy, we have significantly improved management outcomes in RVO, representing a critical advancement in therapeutic options. Also, as has been discussed earlier, follow-up duration for the neovascularization has now increased to 6 months after the advancement of anti-VEGF therapies. The take-home message from the presentation would be RVO is a common cause of vision loss. In fact, it is the second most common retinal vascular disorder after diabetic retinopathy. Systemic diseases play a major role. Hypertension, diabetes, hyperlipidemia are the most significant risk factors. Thrombosis is the key pathophysiology. Venous stasis, endothelial damage, and hypercoagulability that makes Virchow's triad contribute to the occlusion. In the central versus branch RVOs, CRVO has worse prognosis than BRVOs. In ischemic and non-ischemic, ischemic has high risk of complications like neovascular glaucoma and that requires close monitoring. Macular edema is a leading cause of vision loss and it is essential for, and OCT is essential for diagnosis and treatment planning. Anti-VEGFs are the first line therapy. Steroids and laser therapy acts as adjuvant. Steroid can be used in resistant and inflammatory cases, and laser helps in neovascularization, although it may cause field loss. Systemic evaluation is crucial as it may be a marker of underlying cardiovascular disease. Patients should be screened for systemic risk factor. Early diagnosis and timely management improves outcomes. Prompt intervention can preserve vision and prevent complications like neovascular glaucoma and permanent vision loss. Thank you.
Thank you, Dr. Bharti.